Even though we have the second lowest smoking rate, we have the second highest lung cancer incidence rate and death rate. And so what we're seeing in California is that lung cancer is on the rise in never smokers, particularly Asian women never smokers. Lung cancer is dramatically increasing, doubling every year, and they're being diagnosed more at stage 4 because we don't have a screening test for lung cancer in the non-smoking population.
Since they don't fit the criteria for screening, what is it that they could do? No one wants to be at risk and then not even know it. Is there something that they can do or ask their physician, or what is it?
The most common symptom that you get, first of all, is nothing. It's silent, asymptomatic. But the next most common, 60 to 70% will always have a cough that's ongoing. Asian women are more likely to be diagnosed stage 4 because they wouldn't expect it and there's no screening test, and people aren't thinking this cough isn't going away. It's probably just asthma, or it's probably just allergies.
Hello. This is Kenny Perkins, aka your cancer guy. And again, as I tell you always, listen, we always have phenomenal guests, and we're not short. We're not running short, and they just keep coming. And right now we're traveling up to Northern California. This next gentleman we have on our show is a thoracic surgeon, and he cares so much about his community and the things that he's doing. Lung cancer, we see a lot of that these days. And not only are we seeing a lot more lung cancer on the rise, you're seeing a lot of lung cancer with people who don't even smoke. Some of the risk factors that you're associated with lung cancer, but we're not seeing that, and people are still being diagnosed with it. And so we're going to tackle some of these issues. Different communities are exposed to different diagnoses, and I don't know, is it genetic? What is it? We're going to get into that a little bit today. And so if you're someone who has been diagnosed with lung cancer, you're a little nervous about what to expect, what's going on when it comes to getting maybe a second opinion, right? A lot of times people are afraid to get a second opinion. Hey, my doctor said this, and then they're stuck. They're only doing what their physician says, and that's not necessarily a crack on the physicians. I'm not saying that the physicians don't know what they're talking about, but what I'm saying as a patient advocate, have you gotten a second opinion? Do you know for sure that what has been given to you is that? It never hurts. A second opinion, you're not hurting anyone's feelings. And number one, there's only one of you. So make sure you take care of yourself, because no one's going to take care of you better than you. And so today we're bringing in our next guest, and I'm telling you, as I told you before, this gentleman here, he cares about his community. He's an awesome surgeon. People are coming to him from around the world. And it is my honor to bring in our next guest, Jeff Velotta. Jeff, welcome to All Talk Oncology, my friend.
Thank you, Kenny. Thanks for having me. I've been a huge fan of your stuff and the podcast, and especially the patients that are on. So I'm just super stoked to be on. So thank you for spreading the word. I appreciate it.
It's my pleasure. My pleasure to have you, and it's a privilege. And Jeff, talk to me a little bit about your background. Let those who are listening, who is Dr. Velotta, the thoracic surgeon? How did you land in this field and get involved with the way you have been?
Yeah, so basically I'm just born and bred California, from Northern California. I'm from a small little suburb called Walnut Creek. So now I'm back home, basically. I'm Japanese American, 4th generation. So my grandparents, speaking of Remembrance Day and all this stuff coming up, my grandparents were in the internment camps that after World War II. A lot of my heritage and stuff with the Asian cultures stayed with me, even though I'm 4th generation. I'm fairly culturized and whatnot. I still bring a lot of that Asian flavor with me. And then from there, it really just, with thoracic surgery, it does have a little bit to do with family, right? So my grandfather died of lung cancer. And so I think that just leads you into that field a little bit, right? And then my dad has had a bunch of chest surgeries, open heart surgeries. So just having family and being around it all in the Bay Area in Northern California, where I grew up, was like, yeah, maybe it's time, to focus on that field. And that's why it was always there for me. And now I've been here for, I don't know, 11 years now up in the Bay Area practicing here. So it's been really fulfilling to come back and like literally live 2 miles away from where I went to high school. So
Wow.
One of those stories.
Yeah, for sure. You're definitely a man of the community. I love that. It's not only is it honorable to see someone who's known that your grandfather passed away and you're like, you know what, I'm going to get involved. I want to be a solution in this area. And it's so honorable. And I love that. Talk to us a little bit about some of the things that you're seeing here as a thoracic surgeon. Is there a trend? Is there something that you're seeing these days?
Yeah, thank you, Kenny. And I know you being from Southern California, but in California, lung cancer is different. Okay. In California, it's not that it's different per se. I'm not saying we're super special or anything, but what we're seeing in California is, let's go over some of the numbers, right? California is in terms of the smoking rate, it's the most populous state, right? We know that it's 40 million people. We have the biggest state in terms of the numbers. However, we have the second lowest smoking rate. Yet, even though we have the second lowest smoking rate, we have the second highest lung cancer incidence rate and death rate. And so what we're seeing in California, both Southern and Northern, but specifically where I practice in Northern, is that lung cancer is on the rise in never smokers, particularly Asian women never smokers. Lung cancer is dramatically increasing, doubling every year currently. And that's what we recently published in Chest over every other race, ethnicity, and smoking. So lung cancer, a lot of people think the misnomer is around the country, which lung cancer is declining, which it is, but it's actually increasing, especially in younger Asian women, non-smokers. And they're being diagnosed, Kenny, more at stage 4 because we don't have a screening test for lung cancer in the non-smoking population. Whereas in the patients with a smoking history, yes, we have very good lung cancer screening, but you have to be at least smoking 20 pack years, right? Or a current smoker. And you have to have quit recently within 15 years, which, no offense to the USPSTF 2021 guidelines and all that, this data was all done based off of white men 20, 30 years ago when there was a smoking history, when you and me maybe were younger and you're used to seeing somebody like the Marlboro Man and those commercials and stuff. That is not like that anymore. Yet our guidelines for screening are still based off of those old guidelines. And we're missing out on this population that we see in California, meaning 30% of our patients in Northern California don't have a smoking history at all. And the majority of them are Asian women.
Wow.
And so I call it a crisis. So that's why I'm glad you're able to bring that up.
1000%. Obviously, it's a crisis. When you have people who are not smoking getting diagnosed with cancer, you're like, what the heck is going on here? Since they don't fit the criteria for screening, what is it that they could do? No one wants to be at risk and then not even know it. So is there something that they can do or ask their physician, or what is it?
Absolutely. Family history, meaning that genetic part of it, is what we think. Now, it's multifactorial, but through a lot of research in Taiwan, family history was actually the strongest risk factor for these Asian women. Okay. And so if you have a family, so what can you do ahead of time, right? If you have a family history of lung cancer, especially in multiple relatives, the highest risk, and on mom's side, the highest risk. So if your mom had lung cancer, regardless of smoking for them, and then say mom's grandma or mom's sister, or you as an Asian woman, your sister and brother, all of those, especially more first degree relatives, not necessarily distant relatives, that's something you have to let your doctor know. Now, it doesn't mean they're going to screen you because they may not know all this phenomena, which is why we're trying to get that out there. But you are at higher risk, you as the patient, and most patients will be listening, or the people out there in the community. So the family history is a big risk factor. But there's other things you can also do. We still know that for some reason in the Asian community, and I used to think this is a stereotype and I used to not be really cool at this or whatnot, but it's really true. A lot of the traditional Asian, or not even traditional Asian Americans, cooking oil, fumes, the wok cooking, right? Poor ventilation. Not everybody lives in $1 million house in California, despite what everybody thinks, right? There's the majority of the population does not live in that level. So they don't have good cooking ventilation. They cook a lot. The women do a lot of the cooking. It's a lot of some old school traditions where the woman's always cooking under a high heat, oil. We're celebrating Lunar New Year today, and my wife is Vietnamese, and I know there's going to be crazy cooking. So I tell them you got to make sure you have good ventilation. You're not going to get anything if you at risk if you just do this once or twice or whatever. But these are over years of exposure. In China, they've shown cooking oil fumes, huge risk factor. Okay, so if you have that, change that up. And we know this, you can't just be under the cooking oil. It's the high heat that's an issue. Radon. You can test your home for radon. I tell everybody to test their home for radon. Radon is an inert gas that nobody knows about, but it's in the soil. And you could live in a $3 million house and still have high radon levels. That's a huge risk factor in these non-smokers. And then just all their histories of lung illnesses. If you've had a history of even COPD, like emphysema regardless of smoking, or this long history of interstitial, like inflammatory lung diseases, and even a history of TB, especially a history of TB from Asian. It's very common in Asia. So when women come over from there and they think, oh, I had a history of TB, they don't think that is risk factor. Those are actually all risk factors specifically for lung cancer. So I think if you combine all those factors, you have to be thinking in your mind, hey, these are risk factors in me as an Asian woman or as an Asian male that regardless of smoking, that actually would put me up at risk. And then lastly, this is a little bit harder for people to take, but there are higher pollution levels in certain areas of California, even where I live, and even higher in Asia. So in Asia, it's really, really high. In China, it's very common to have these air quality indexes of like 500. But even in certain areas in California, we're seeing the air quality index being a huge factor, and that has been shown to be a risk factor for lung cancer. So where you live, just being in that environment, and then really what's come up recently, especially me in the Bay Area, and you just had that in Southern California a year or so ago, wildfire smoke. 2 studies have recently come out about wildfire smoke. If you're people that are lighting, still using the chimney and fire, which you're not supposed to be doing, those are risk factors for lung cancer. So if you put all that together, it starts to add up where you can see maybe, hey, lung cancer it can be related to other things that not related to smoking.
For sure. My goodness. You're dropping some gems today. I mean, that's a lot. And I hope, and that's the beautiful part about this. There's a lot of gems you can always come back. Those that are listening in, listen, any of those factors are worth looking into, especially if you are a minority, cooking with the wok, as we're talking about an Asian community. Here where I'm at in Los Angeles, we have a huge, large Asian community, and we want to make sure everyone is healthy. We want to make sure that you're in a good place. So, Dr. Velotta, what would they ask their physician for? What is it, a chest x-ray? What is it that you screen, even though they're not a candidate? What could they ask for?
Absolutely. Thank you for bringing that up. I was going to go into that next. So it's an imaging test. So ideally, you're right, what they're going to ask for. So the best test, the gold standard test right now, until we get this beautiful lung blood test and all the stuff that I know you've been talking about on your show too, we don't have a blood screening test yet that's perfect yet. But until then, it's this low dose CT scan. Okay. A low dose CT scan. It's minimal radiation dose. So it's not going to increase your risk of cancer. It takes 1.5 minutes to do. There's no IV contrast or nor oral contrast that you have to drink. So it's very harmless. That is the gold standard test that will pick up even small things. Now, with that being said, that can often cost anywhere from $1,000 to $2,000 out of pocket. And even with copay of $500, $600 regarding what kind of insurance you have, because right now it's not covered by your insurance. Now, so I'm going to give a little pearl, hopefully, to patients. And I don't want every patient on your that's listening to say, "Oh, I'm going to go get a CT scan. This is how I'm going to do it to get past the system." But technically, what I usually say is, it changes if you're having symptoms that aren't going away. So if you do have a cough that's not going away, and you have some of the risk factors that I talked about, those are the patients. What we're really saying is, you do need to go see your doctor. Say it's not getting better with acid reflux medication, or it's not getting better because they put you on antibiotics, or you got over COVID and you're still having that lingering cough. Because bottom line, the most common symptom that you get from lung cancer, early lung cancer, first of all, is nothing. It's silent, asymptomatic. But the next most common, 60 to 70% will always have a cough that's ongoing. You often hear about that. Just a dry cough or any kind of cough. And so when that happens, we do recommend you go see your doctor, because you need, at a minimum first, at a maximum, what you want is a CT scan. But not all doctors are going to know. They're not going to be like, let me just get you a CT scan. So I'm thinking lung cancer, right? That's the last thing they're thinking. But at a minimum, what I'm getting into next is you get an x-ray, right? We know what a chest x-ray is. A chest x-ray is a small little picture, minimal risk, takes 2 seconds, very cheap. Even a copay should be anywhere under $50. It's a very cheap and easy test to get. So a chest x-ray will at least show if something's brewing. Now, it doesn't show something tiny, but will often show something that could be of concern. And then what do? They follow that up with a CT scan. And then it goes to the diagnostic workups. Not that I want to get into insurance and all that stuff, but it starts going under a different pathway other than screening. So then you get the appropriate follow-up. And then that could be like something, look, we see something now. And so you can get these things done with not suffering monetarily too much because now they see something. But the key is you got to get in there to get that at a minimum X-ray or low dose CT scan to catch something. Otherwise, it'll be too late. You'll come in when you have too many symptoms, weight loss, coughing up blood, can't breathe. That's the problem. That's what we often see in these Asian women. They've had this lingering cough, Kenny, and then it's like, well, it's been on for a year. I tried my inhalers. It didn't work. Nobody really did it. And then it just kept lingering. And then they get a scan. And that's usually why, unfortunately, when it's symptoms going on that long, we often catch, again, and this is a proven fact in research that we've done, is that Asian women are more likely to be diagnosed stage 4. Again, because they wouldn't expect it and there's no screening test and people aren't thinking, you have this cough isn't going away. It's probably just asthma or it's probably just allergies. It could be, and most likely will be, Kenny, right? Majority of women that are Asian out there are not going to have lung cancer. But if you do have some of these other risk factors that I've been talking about, plus this lingering cough or things, I would go in tomorrow to be like, hey, at least give me an x-ray first. And your doctor usually, especially if you say symptoms, again, I don't want to cheat the system, but if you're having symptoms, I don't want you to lie, but if you're having symptoms like cough or shortness of breath, that's a reason. They're not going to say, no, I'm not going to get you an x-ray. They're going to be like, hey, this is a little bit odd. So that's the way I work it out in terms of what could be done that can help you earlier.
I love that. I hope you guys are taking notes here, because if you are having any symptoms and you've been exposed and these things are happening to you, well, we don't want you to wait. Early detection is the key. If you can catch this thing early, we can take care of it and you can go about your life. We don't want to wait till stage 4 and then we're now trying to problem solve at that point, right? No, we don't want that. So I hope you guys are taking notes on that. I love it. I love what you're doing. I love your passion. And you can see it, Dr. Velotta. It comes through. It comes through. And we really appreciate that. A lot of times what we also see here is people coming in, getting surgeries, or being diagnosed without getting a second opinion. And we want to get your thoughts on that. Is it okay to get a second opinion? A lot of people feel nervous, right? The doctor said it, this is it. It's one and done, versus going, let me double check this.
100%. I believe in second opinions. I think it's a very good thing to do. And it could be just even with a different doctor that's in the hospital system. It could be outside the hospital system, however you want to do it. But getting different opinions is very important because especially with lung cancer and cancer care now, it's so advanced. There's technology changing every week that you can't assume that your doctor may know about everything. And you may be in different parts of the country where maybe you're in more of the rural area, or maybe you're in an area that this doctor doesn't see as much lung cancer or whatnot because it's so specialized. So I think that is why, with the advancement of medicine and with just so much knowledge out there, and with AI and new medications and new different types of surgeries and techniques, you just can't assume your doctor knows all of the newest stuff or the newest trials. There's clinical trials like mad everywhere. And so that's why, especially with lung cancer, you really do need to get another opinion. And to answer, so that's first and foremost, I agree with it. Second most, what you brought up, Kenny, I think is great. Us as doctors, if your doctor, when you ask for a second opinion, if they get offended, you got to think about that. You got to think about it with that doctor. I'm not saying they're trying to hide something, but they're either old school thinking, which is kind of what we used to think, oh, you never ask, just respect your elders and your peers, but new school thinking, at least a lot of the way we're trained now and things, we're open to that. And we want that because we also want to see what our colleagues may say. And maybe they have some advice, or maybe what they say we can learn from. Just that's why we go to conferences and medical meetings, to learn from other people, because there's so many different ways to do something, even for basic, regardless of what stage you're in. So I think, your doctor should be open to that. And so you as the patient should not be scared and worried about that, because your doctor, in my opinion, should embrace that and say, that's great. I want you to. If they don't, you should still do it on your own without that. But you should also think, maybe is that doctor the right fit for me? And it may not be. And we see that happen, as Kenny knows, talking to all patients, that happens all the time, especially in the oncology world. And that's okay. And don't think you're being the bad patient or the difficult patient because of that. That is, you as the patient have that right. And like Kenny, what you said earlier is perfect. It's only you. You're only one person. So what, another opinion or whatever, it's on your life. It's your life when it comes to cancer for any disease process or whatever you want to call it. So I do think that patients should opt for that, in my opinion.
Love it. Dr. Velotta, that's what makes you the popular guy. That's what makes you an approachable person. Popularity is not always the thing when you're dealing with a physician, but it's a physician who's confident to know it's okay to get a second opinion. And when you come back, we're going to address these things.
Yeah.
And it makes the patient feel that they're not walking on eggshells. They feel confident about the decision. They feel a part of it. And I see that you bring that to your patients, and I love that energy for them. And the second thing you brought up too, and it's a point, how do these patients find out? Because there's a lot of different trials out here. There's a lot of different new medications that maybe some physicians may not know. So how do we bridge that gap in coming together?
You're right. And that's perfectly right, especially with clinical trials. That's the hardest thing because patients, especially if you're not in the medical community or you don't have family that's in the medical community at all, it gets even harder. It really helps when you have family members. That's why I actually love when family members have or are in the medical field a little bit because they're a little bit more nuanced and they understand stuff. So I can get really nitty gritty and then they're looking at things too. So it's cool. But not everybody's going to have that. And I know that. So when you don't have that or you have no background in that, one of the things that I'm seeing a huge part of which is why I think it's great that what you do as patient advocacy are the patient advocacy groups. For lung cancer, there are so many now out there that actually have what's called, like, for example, I'll just give an example, Go-To Foundation, right? They Go-To for lung cancer, longevity. They actually have match programs where they have just patient advisors out there that are there to match you based on what you come in with your type of lung cancer for different trials. And they don't have to be the mainstream trials or even the experiment, like the brand new trials. So I've seen a lot of that. And I've actually referred a lot of patients to that. So first and foremost, that's the ones where you can just do on Google and be like, oh, lung cancer advocacy. And you see these patient groups and then they hook you up with different clinical trials that you would be for. And then they put you into the patient support groups where other patients that are on these trials or looking for a trial that can't find a trial, for example, a vaccine trial or a CAR T cell trial, that are looking for that, they put you in that group. And like, I just had a patient that went to Mexico to find one, and she found one that they're doing a special in Mexico that there was no options here. I'm not saying everybody should go out of the country, but that's how this group brought her in to find that. Even outside of the country where there may be different regulations and all that stuff. And I'm not promoting one over the other, but sometimes you just have to really think outside of the box with that. So I really like that. And then secondly, Kenny, what each hospital system does have, no matter whatever hospital system you're in, whether it's Kaiser or academic, the VA or whatever, they do have clinical trial specialists that just revolve around cancer clinical trials, and they have a whole list of all of them. So what I recommend patients sometimes do, or actually always do, depending on how quick we can get these things done, because that's another thing that we won't go over. There could be a time lag between when you find a clinical trial and then enrolling in one, right? You don't want your cancer to get bigger, but that's a different topic. But at least to find clinical trials, your doctor should be, when you talk to them, especially your oncologist, even your surgeon, radiation oncologist, but especially medical oncology, they actually have a clinical trials person at every hospital that'll say, okay, if we don't have this clinical trial here at, say, I'll give you an example like Kaiser, then here's a list of the other ones that you as the patient can go out and see. And so there is a clinical trials person. So I often say to patients to ask your medical oncologist, hey, are there any clinical trials, by the way? Because technically, I know patients may not know this, technically, especially when we present in tumor board, if you're presented in tumor board, multidisciplinary tumor board, or just seeing the doctor for the first time, we're actually supposed to go over, oh, are there any alternatives to this surgery or to this treatment? Meaning, are there other clinical trials that may benefit you as the patient other than what we may consider standard, whether it's radiation, chemo, and in surgery, that's always considered standard, but there are so many new novel treatments in addition to that we're supposed to really talk about that. But as in this day and age with timing and trying to get all this out and talk to a patient just about the regular standard treatment, we don't have time to go, oh, here you go, Mr. and Mrs. Smith. Here's this also. Let me talk to you about clinical trials. Like you and I both know, like that's not real, like really in reality, what can happen in that amount of time. But just know that they actually do have a clinical trials person that should be able, or is supposed to give that to you. That probably doesn't happen the majority of the time.
For sure. And so, and that goes back to you. Thank you so much for that, Dr. Velotta. But that goes back to the patient. You can't expect everyone to have all of the answers. You go to a physician to get the answers, and I'm saying that's the truth. But do your part is that you can ask these questions. Is there some clinical trials or any alternatives or anything that can supplement? And it's just asking the question and then see what comes back your way.
Yeah.
It's okay. It's your health. It's you as a person. You want to make sure that you get the best possible treatment that is out there as of today so that you can be whole again, so that you can live your life and put this chapter behind you. So I want to make sure that you are put in a position that you are having the best possible outcome. So thank you so much, Dr. Velotta, for bringing that up and talking about it. And as I have you on the show, it's a privilege. I would say, how many surgeries do you average per week?
Love that.
Give us a perspective.
Yeah, I love that because that's the next question I was going to say that for surgeons, that's what you have to ask. You should ask me how many. You as patient advocate and moderator, but as a patient. And so for me, for example, people, I always expect them to ask that. So I'm ready for that because I always look at my numbers every year and stay current. So I do about 250 lung cancer cases a year. So that's what I will tell people. And then on average, I do tell them the truth. I operate on Mondays and Wednesdays, full days that start at 8 and end at 5 or 6. And I can get anywhere from, depending, every surgery is different, but anywhere from 2 to 4 to 5 cases during that time period. So I love that question because I do think patients that I do know as a surgeon, I very rarely get that question asked, maybe 10% of the time. That's the question. If I was anybody, because you're going to see me as a thoracic surgeon, I would want to know, how many have you done? How long have you been doing this? And a lot of people will ask me, which I like to know too, when I had a family member go to the surgery, is do you have residents? Do you have students? Do you know who's doing the surgery? Are you running 2 rooms? I'm not saying people understand to know this, but there's a lot of, you're in the medical field too, there's a lot of things that we have as clinicians in this busy time of world that we're juggling. And that's during your surgery often, or during the overall process of the operating room and all that, which I don't expect patients to know, but there's a lot of stuff going on. So the more questions you ask, the better. And hopefully they'll give you a straight answer. If they laugh it off, which happens, I get all the time, patients will tell me all the time, he didn't tell me, or he said, don't worry, I do tons. Like another answer that you'll get sometimes, don't worry, I do tons. Or do you see how old I am? You can tell that I've been around. That's what I've heard doctors say. So that tells me you can be old, but it doesn't mean you're operating every day. I'm always prepared for that question because I remember 10 years ago when I was asked that question, I just had to tell them the truth, which is, hey, I just started, but I trained in Boston. I feel very comfortable. But yeah, I've only done 20 cases so far, like when I first came out in 2014. Whereas now, yes, I'm a little biased because I can be more honest because I'm 11 so years out of training. So yeah, of course, I have a lot more under my belt and feel more comfortable and do a lot more because I'm just, right? You get, just like any field, you're more senior, mid-career, however you want to call me. And so I feel more comfortable saying that. So I'm ready. But your doctor shouldn't say no or throw you off with that, especially your surgeon. If they do, just think of the red flags. I hate using red flag, green flag, but that is a red flag in my opinion, because it's either their personality is a little too standoffish, or maybe they're hiding something and they don't do that many of these cases and they need to survive. They need your surgery to come in. Let's be real. It's still a economy where we need to do things. And my job, their job as a surgeon is to cut and sew. Even though they're small now, minimally invasive, that is how we live and survive in the world, no matter what practice you're in. So you got to remember there's a little bit of these fine balances. But I love that question that you asked. And that's why that's my answer, because I'm ready for that. But I do think more surgeons need to be ready for that, because classically we weren't asked that. And even now, like I told you, only 10% of my patients ever asked that.
Yeah.
Surprising to me.
Yeah, I love that. I love your honesty. And you look for that. And I'm not saying that just because you're in front of me. I'm saying that because that's what you're giving me. And honesty and someone who's upfront is what you look for when you're going through some type of treatments. If you're going to go through a surgery, you're going to go through a treatment, you're going to get any type of procedure done, you want to make sure that your physician is upfront and giving it to you. I don't say raw. You want to have bedside manner, but in an honest way. And so I really appreciate that about you. And now it's my turn to put you on the spot a little bit, because here we are. We have a lot of things going on as a thoracic surgeon. I'm going to ask you, are you guys working on anything, and you have any clinical trials that you're doing up there where you're at?
Yeah. The exciting part is, the short answer to the question is yes. We're really excited because, and I can't go into the full details, but I will tell you that, like I said, because we're seeing so many Asian women non-smokers with getting lung cancer at later stages, we wanted to say, hey, let's catch them in earlier stages. So let's run a trial where we do a CT scan on Asian women that don't have a history of smoking. But we also looked back at our data and we found family history, and we extrapolated data from Taiwan and other places that family history is one of the strongest risk factors that we think in people that don't smoke. And so if you have that family history of lung cancer and you're Asian woman, regardless of smoking, we're screening them with a low dose CT scan. We don't have the full results yet, but I will tell you, this is enlightening. And I think this is going to change practice. Give us 6 more months. But I do think from what I'm seeing now, this is going to be a very valuable tool, meaning I do think the standard, what I'm hoping is that we can open this up. So it's not just this secret clinical trial that we only have funding for a certain amount of women, right? Because that's part of the issue, the funding. We have to pay all this because we don't want the patient staff to pay for a CT scan and the follow-up, and if there is follow-up. But I will tell you, I am excited about it because I do think it's going to be very worthwhile and hopefully change practice in the coming year. That's another thing, in a year or so. I don't want to wait 10 years. I love randomized controlled trials. We love like the classic double blind, don't know what's going on, wait 10 years to see the survival outcomes. But in certain cases, like this crisis that we talked about for lung cancers and non-smokers, we don't have time for that. Our parents, your parents, my parents, whatever, whoever, family members, sisters, brothers, they're getting that now. And so we need to act quicker with studies that align with current stage thinking and not like old school thinking, which is you need 10,000 patients and you need to make sure no doctor sees and double blind and randomized control. I love those, but that just takes too long. And so I'm hoping with this study that we're going to find some meaningful results where we think it's going to be, hopefully, we don't know yet, but I think it's going to be beneficial. Absolutely. I think it will be helpful to potentially get a CT scan in this certain high risk population. I'm not saying screen everybody with a CT scan, but this certain high risk population with a family history, I think this is going to be a game changer.
Dr. Velotta, what I really appreciate about you, one, thank you for putting something together like this and being a part of a clinical trial like this, because it's needed for these high risks and people who are not smoking. But I just want to point out and give you your flowers here to say, you know what, you're doing a lot for the Asian community. And it's a blessing to know there's someone out there, a physician out there that's advocating, that's looking, that's actively participating in getting someone in their culture better health, but not even just your culture, but just overall as human beings. So I want to stop and say thank you so much for what you're doing. We really appreciate that.
Well, thank you, Kenny. Thank you for, I'm just trying to do my part in small ways that I can at least relate to. And so that's a passion of mine. So thank you very much.
For sure. And I do that sometimes. It's like in a small way. No, it's a huge way. Just from this interview alone, I found out here that your grandfather had lung cancer. You became a thoracic surgeon. Now you're putting these things together for people in your community, and then we do that. It's a small thing. No, it's a huge thing. And I want to give you your flowers for that. I want to tell you, man, thank you so much for being out here, for being passionate the way you are. And it comes across. And so I want to say that. And thank you.
Thank you, Kenny. Thank you for having me on, man. I love what you do, and I learn so much from your patients, especially the patients. I mean, that's where I learn from a lot, because I kind of see the different patients' views and stuff, and that's what I love about it. So keep up the great advocacy work. Thank you very much.
Appreciate it. Now, before we let you go, because I know you're a busy man, what would you like the patients to know before we let you go?
I think the biggest point that I would love out of everything we talked about is that it's okay to ask your doctor what you think may be the tough questions. It's your life. Ask the tough questions, or ask the questions that you think are maybe too personal, right? Or especially in the elderly population, they're very respectful, and you're not being rude by just asking questions. You're just asking what comes to mind and what you may be thinking at home that you're afraid to ask, whether it's how many surgeries you've done, or do you treat lung cancer all the time? Like, you'll be surprised. A lot of the doctors you have treat every different kind of cancer. Imagine trying to figure out leukemia, breast cancer, prostate cancer, and lung cancer. To me, it's crazy. But in reality, most oncologists, or even thoracic surgeons, we treat a lot of different cancers. Ask them the tough questions. What do you feel about lung cancer? If we're talking about lung cancer here, really ask the tough questions. And I just don't see that enough. And I tell my family members to do that if they go see a doctor. Maybe not give them 50 questions or whatever, within reason. But I think asking the tough questions that you normally feel uncomfortable with, I think you have to get out of that comfort zone, go advocate for yourself, and ask some of those questions, because you may learn a good amount. whether a beneficial thing or maybe a way that says maybe this is not the right fit. Usually it's going to be the right fit. Don't get me wrong, Kenny, but at least you want to learn a little bit more. I think it's okay to be a little bit more personable. You don't have to be buddy with your doc, right? But at least get a little bit more out of them than just the kind of old school patient physician. You are the patient. You listen to Dr. God, right? That I think should change. And it is changing, but I do see a lot of that dynamic still around, especially since I travel a lot and go to medical conferences and meetings. You still see some of this thing in the hierarchy. And I think that hopefully the patient, you can go out there and do your own thing.
Yes. Thank you for that. Appreciate it. Dr.
Yeah,
Velotta,
thank you.
yeah, it's a privilege to be able to have you on the show. Thank you so much for cutting out some time. And listen, if you guys tuned into this, Dr. Velotta is giving you a lot of information. We're going to make sure we drop his information in the comments so that way you can get in contact with him. If you're up north and you're a candidate for some of these trials, you're someone having symptoms and need to see a second opinion or just see a surgeon period, then we're going to make sure that his information is available to you. So I just want to let you guys know here, thank you so much. And always remember, you're not alone in this. We're in this together. This is Kenny Perkins, a.k.a. your cancer guy. Until again, I'm out.
So stay connected with us on All Talk Oncology Cancer Podcast. Make sure you subscribe to that, right? Wherever you listen to your podcast, whether that's Apple, Spotify, make sure you subscribe and continue to spread that word, right? Engage in this because your engagement can help someone stay alive. And this is what we're talking about. So again, make sure you subscribe, hit that subscribe button. Again, this is Kenny Perkins, aka your cancer guy. Until again, I'm out.